So welcome to Decoding DX. I'm Brianna. We have a really fun case tonight. We've got an awesome third-year discussant, Zach, who's graciously joined us despite being on his surgery rotation. And then he's going to be discussing with John, and then Dr. Zufer, if she's able to join us tonight. She had clinic today, so she may be a little bit delayed from clinic, which is the medicine life. So let's go ahead and get started. So Zach, tell us a little bit about yourself. What's something fun about you that has nothing to do with medicine?
Hey guys, so I'm Zach Duarte. I'm a third-year medical student. Something fun about myself. I fly RC planes, or I've actually taken apart more because I usually crash them and then, yeah, I break them and then I don't put them back together. But yeah, I fly RC planes. Yeah.
Awesome. And then John, we all know you, but go ahead and reintroduce yourself again, just in case there's any new one on.
So I'm John, a fourth-year student, going into medicine. Something interesting about me, I'm an aspiring Jane Austen novel enthusiast because my mother-in-law has a master's degree in Jane Austen literature, and so I was disowned for not having read them in the past. So
that's amazing. I love it. And then we have the amazing and beautiful Kelsey scribing for us today. So she's manning the board. So let's go ahead and get this ball rolling. This is going to be another more treatment-focused case, kind of like last time. And then whenever Dr. Zufer gets here, we'll integrate her in. So to start out, we have a 58-year-old male who is presenting to the emergency department for worsening cough and shortness of breath. So for the sake of discussion, I'm going to just leave that at the aliquot for now. I'll give more HPI afterwards, but I just want to know, Zach, let's start with you. What kind of comes to mind when you hear 58-year-old male cough, shortness of breath in the ED? What are you worried about? What are the first things that hit your head?
So generally, when I think about this, I want to think about it in terms of acute and chronic problems. So the acute problems are the things that are could kill you now. So cough, shortness of breath. You could think like PE if you want to get that ruled out right away. You could also think pneumonia. You could think shortness of breath. I mean, certainly chest pain. A lot of times goes with shortness of breath, so like a heart attack could cause that. More chronic problems, I mean, it could be stuff like asthma, COPD, things along that lines. So the common ones.
Yeah, for sure. Common things are common. That's definitely a mantra to live by. John, what else comes to your head?
I think when I think of like dyspnea for starters, usually kind of think of pulmonary primary, cardiac primary, or things that are unrelated. So some other things with shortness of breath, not so much cough. You might see like a panic attack, things like that. So there's kind of some of those non-cardiac things. I mean, we can talk about those things for days and days. But another thing with worsening cough and shortness of breath is definitely like pulmonary edema in the setting of heart failure. So that's a big one as well. And then other things for, shortness of breath, weird cardiac things. You can have other, like, in addition to MI, CHF, you can have arrhythmias. You can have, I've seen people in the ED who are in AFib, and it's kind of a worsening of their cardiomyopathy, and that's kind of manifesting itself in shortness of breath. But when you have that cough, oftentimes, you're thinking like something infectious, something respiratory, something COPD-ish is the top thing that I'm thinking about.
I love it. Again, common things are common. And Zach, one thing that you said that caught my attention, thinking about shortness of breath, that can be with like, is there any chest pain? The Curious Clinicians actually had a podcast that came out today that was like an awesome discussion about the possible pathophysiology of shortness of breath with MIs and kind of like why that happens. So I encourage everyone to listen to that. It's really cool. Okay, so I'll give you guys a little bit more HPI. Is there anything specific that you would want to ask this patient right up front before I tell you that?
I would say any chest pain for sure. And then I would want to know any other associated symptoms, anything that's bothering them, and then would want to know about the chronicity of how long it's been going on, anything related to any other infectious things. So are they having fevers and chills? Are they having those things? Did they have fevers and chills a week ago and now they're having these issues? And then also, you know, their underlying past medical history. Do we know they have asthma? Do we know they have COPD? Stuff like that, I think, would be the main things. Getting a good history is obviously very important for shortness of breath.
And one way, like for the M1s and M2s to work through that is generally, you can start off like the old CARTS mnemonic or the OPQ or STI mnemonics are a good starting point, and then jumping off from that, because that doesn't include everything, like John was saying, you know. So like things like fevers, chills, stuff like that would definitely want to be added on very quickly to that.
For sure, I love it. Dr. Zufer, welcome.
Thank you. Sorry, I didn't want to take it from work because that meant I would get on the meeting by 45 or something.
Yeah, so, no worries. Just to catch you up to
Hello?
speed, we have a case of a 58-year-old male presenting to the emergency department with worsening cough and shortness of breath. So that's as far as we had gotten with the case presentation. Zach and John had just kind of given their thoughts, and we'll go ahead and move forward with more of the HPI, and then we'll come straight to you after that for your initial thoughts and what's going through.
Okay.
So,
all right.
This is our 58-year-old male. So he was diagnosed with COPD about 7 months prior to this. He had seen a resident as his PCP in the family med department at KU, who had been prescribing him inhalers and some other stuff. And he had run out of these inhalers about 2 weeks prior to presenting to the ED this time. He had tried to get them refilled, but the family medicine resident had graduated and he didn't get plugged in with the new PCP. So something to think about being at an academic center that we could see our patients run into. So since then, his cough has gotten worse. It's mostly non-productive. He's got kind of some shortness of breath that's worse with exertion. He does smoke. He said that he's been trying to cut back on that recently. He doesn't have any sick contacts, no fevers or chills, no night sweats. Sometimes he does wake up at night kind of short of breath, but he doesn't say that he wakes up gasping or anything like that. So besides the COPD, he's also got a questionable history of maybe some heart failure. So about 4 months ago, the resident that he was seeing for PCP noticed some leg swelling, ordered an echo for him to look at heart failure. He actually never ended up getting that done. And she did prescribe him just 20 milligrams of furosemide every day, kind of empirically for that. He also had some mild diabetes and had a stroke about 7 years prior to this. He's not on any anticoagulation. His pulmonary function tests in clinic had an FEV1 of about 48% of predicted, and his FEV1 to FVC ratio was 42% of predicted. And this was a few months before he came to the ED. So pretty significant COPD. Medication.
Would you mind repeating the PFT numbers real quick?
Yeah, so his FEV1 was 48% of predicted, and his FEV1 to FVC ratio was 42% of predicted. So medications, he's on aspirin 81, so baby aspirin. He's on the Lasix 20 a day that I mentioned earlier. He's on metformin, and he's on some metoprolol for his history. He was supposed to be taking albuterol and tiotropium inhalers for his COPD, but those are the ones that he ran out of.
Oh, can you say the inhalers again? Which ones?
He was supposed to be on tiotropium and albuterol.
Oh, got it.
So he ran out of those about 2 weeks ago before he came to the emergency department. For health-related behaviors, he says that he smokes, quote, a few cigarettes a day. He's been cutting back. Doesn't drink any alcohol, doesn't use any illicit drugs, and he works as an electrician. So I will stop there, and I'll start with, actually, Zach, let's start with you real quick. What's your problem representation for this patient? What is kind of your summary statement to try and organize this in your head to get focused on what's going on?
Okay, so we have a 58-year-old male presenting with maybe acute on chronic shortness of breath. It's been progressively worse over the past 2 weeks since he hasn't been taking his albuterol tiotropium.
I love it. Short and sweet, get to the point. Awesome. The only thing I would maybe add was that maybe like a possible history of heart failure. But other than that, I think that was a great summary statement. Dr. Zufer, if you were seeing this patient, you know, maybe, I don't know how much you do inpatient, but, you know, maybe you're working an inpatient month and this patient, because he had been seen in the family medicine clinic, he's being admitted to the family medicine inpatient team. What are the first few things that are running through your head? What are your biggest concerns with this patient?
Hello, can you hear me?
Yep, go ahead.
Oh, all right. So tell me first, was this a presentation in the ER? I forgot. What did you do? This is the ER. Oh, okay. So I guess in terms of the history, you did a good job. You have kind of most of the details and even some of the differentials that I would be thinking about. So next thing would be, is the patient hemodynamically stable? So how would you kind of assess that? Any ideas?
Zach, what do you think? How would you assess this patient in the ED?
So the first thing, I mean, so it depends. So if you, a lot of times, like the first thing you'll do is you'll just look at the patient. And I think as you kind of grow in that knowledge of like what's sick and what's not, you can kind of just look at someone and say, okay, you're sick, okay, you're not, kind of a thing. If this person is like gasping for air and isn't able to, you know, catch their breath, they're talking maybe one-word sentences or one word and then taking a breath, one word, taking a breath, versus someone who's just like nonchalantly laying in bed and then says, hey, I'm out of breath, you know, that's different. But otherwise, so the things that you're going to look for are to assess for like hemodynamic status, you're going to look for vital signs. So those are going to be probably one of the first things that they're going to get. The nurse at the door is going to get the vital signs. And that'll be a good jump into, or at least baseline point for you. I think your exam is going to go a far way into telling you more about this patient's status, as well as like, so again, in shortness of breath, just talking to them and seeing how much they're able to. I don't know.
Yes. Yes, you got the gist of it. Yes, excellent. So one is just like, you know, eyeballing the patient. If they are like gasping, they're getting cyanotic and they're turning blue and can't complete sentences. And then there is like intercostal retractions and any signs of like visible respiratory distress, like impending respiratory failure, which might require more invasive stuff. So once you have set that aside and we are not like urgently, oh my God, kind of concerned, then obviously vital signs. And among the vital signs, oxygen levels would be kind of super important, because if the patient clinically does not look like critically sick and the vital signs are all stable, they're hemodynamically stable and not requiring oxygen, then the question is, does this patient even need to be admitted to the hospital? Because a lot of times when we get called to the ER for evaluations and stuff, it is very important to kind of go with an open mind, not with like, okay, what is our diagnosis? And then whether or not an admission is really needed. A lot of times we can kind of evaluate and see like, okay, this can be managed outpatient. So that will be your first step, like, okay, does the patient really need to get admitted? So for that, like you're kind of knowing the criteria, obviously one is clinically, if they're having trouble breathing and they have really bad COPD, then, and they're not going to have close follow-up and stuff, then even if the oxygen level is okay and the vital signs are stable, then okay, the patient kind of comes in. So that will be kind of the first thing, triaging, how sick. So then the next question would be kind of your differential diagnosis. So I know Kelsey, right? So hello? So in your history, you had kind of mentioned quite a few things. So does anyone kind of want to go through the things to consider? What is top of our list?
So we currently, on our screen up here, we have a differential going of pulmonary causes, including PE, pneumonia, asthma, COPD, cardiac causes, including MI, CHF, and arrhythmia, and other causes, including possibly a panic attack. And at this point, John, is there anything particular that you would want to pay special attention to in the labs and orders and exam? That'll be the next aliquot of information that I give. So what are your eyes going to immediately on the chart?
Yeah, so kind of like what we've been talking about, vitals are very important for this. So you want to look at respiratory rate, temperature, and pulse. You're looking for things like a SIRS criteria. They're thinking about, is this a pneumonia, is this sepsis? That's why so, you don't want to look for that because that requires a prompt, workup evaluation. You need to get cultures. You need to start that whole bundle, if that's something that you're thinking about. And then their oxygen saturation is very important too, because, and also something like always be looking at in the chart, you see a normal SpO2, but they're on like 6 liters of oxygen. Always be looking at, what they're requiring to keep their saturations at that. And also if you have the ability to see in the chart if they're on oxygen at home, because if they're on, 4 at home and they're on 4 now, it's like, okay, maybe that's not they have an issue, but it's not acutely an issue. And then other things to look for, like on an exam, I mean, obviously you'll listen to their lungs, you'll listen to their heart, you'll listen or you'll feel, and maybe they'll be on a monitor and you'll see, what's their heart rate, things like that. But, looking for volume status, especially if he has a questionable history of CHF, if you see a really distended JVP and, they clearly are edematous, that might raise some of the other CHF things on your list of things. And then, if you're just doing a full exam on this person, you'll still do an abdominal exam. You'll still, are they really swollen? Do they have other potential causes of shortness of breath? Like maybe he has underlying cirrhosis. I mean, he's been followed, but if he has underlying cirrhosis and he's got like a pleural effusion, things like that, smoking history thing. So you'll want to do like a full assessment on that patient, but those are definitely the things that I'd be looking at initially. Yeah,
I love it. All right, on that note, his temperature is 36.6 degrees Celsius. His heart rate is 64. Blood pressure is 94/59. Respiratory rate is 30. He is satting 89% on room air. And after 2 liters of oxygen, nasal cannula, he goes up to 96%. On exam, he is generally kind of an ill-appearing, thin male, alert and oriented ×4, in kind of mild distress, but that gets better with the oxygen. HE&T is normal, no JVD. Cardiovascular is normal. Pulmonary exam, he's got some poor air movement bilaterally with some scattered wheezing, with some mild pursed lip breathing that is noted. So if anyone that doesn't know, pursed lip breathing means that he's kind of putting his lips together as he's breathing out. Abdominal exam is normal. Neuro exam, he had no focal deficits. Extremities, he had 1+ edema bilaterally, but slightly worse on the left. He had no cyanosis, rashes, or bruising, or anything like that. So overall, exam was significant. He looked a little distressed, some mild respiratory distress, and then just a little bit of swelling in the lower extremities, worse on the left. Initial labs, his white count was 7.4 with a normal differential. His hemoglobin was 13.2. Platelet count was 204. All of his chemistries were within normal limits. For the sake of time, I'll skip that for now. If anyone wants specifics when we're discussing, just ask and I will provide the numbers. His troponin was negative, and his urinalysis was also within normal limits. In the ED, an EKG was done that showed sinus rhythm. no other abnormalities. And a chest x-ray showed kind of an ill-defined opacity in the left lower base that's compatible with a pneumonia and a possible small adjacent pleural effusion. So Zach, given that information, what sticks out to you from the initial exam and labs, and how does this change your thought process or your differential?
So the stuff that sticks out, so I think it kind of goes along with what John was saying earlier. So he's satting 96% on 2 liters of nasal Kenya, but he's still breathing at 30 per minute. His BP is a little low, and so is his heart rate. I mean, it's not low, but if he's acutely ill, it could be low. So it'll stick out to me. But the other thing is, I mean, he's doing like the pursed breathing. I guess just from that alone, you would think like COPD, emphysema. Let's see. I mean, 1+ pitting edema is, in someone like him, I wouldn't necessarily not expect that. It could be a sign of an acute exacerbation of heart failure, but without knowing his previous, it's not of too much use right here. And then, you know, the labs are actually fine. You know, his white blood cell isn't something crazy. His hemoglobin's normal, platelets are normal. Yeah.
Awesome. I love it. That was a great analysis of that. I think one thing that I've heard both you and John really mention is that the difference between sometimes normal values aren't normal for a patient in their situation, and sometimes abnormal values are actually normal for the patient. So it's always important just to keep in mind what's the patient's baseline and what's their clinical context. And so is this value supposed to be normal if they're in this state? So kind of when normal is not normal and when not normal is normal. Lots of wordplay there. Dr. Zufer, what are your thoughts at this point? And given what you said earlier, do you think this patient needs to be admitted? And if so, what would your priorities for management be for this guy?
Dr. Zufer, I think you're muted.
Unmute. Yes. Okay, I'm unmuted now. So yes, the patient definitely needs to be admitted based on all the criteria and all the red, everything that you put in red. The next question is going to be, I guess they need to be stabilized somewhat in the ER. So before going any further, I would like to know the medication list with the blood pressure being 94/59. So he's a little hypotensive. So then we need to make sure that we have a good answer. So do we have a med list?
Yes, so he is on aspirin 81, furosemide 20 milligrams a day, metformin, metoprolol 25 BID, and then he's supposed to be on the albuterol and tiotropium. Okay.
So then one thing is keep in mind that he has a beta blocker on. So number one, that is going to need to be stopped and held. So it is not given with the fact that he is hypotensive. And then the second thing to keep in mind is he might not have tachycardia because he is beta blocked. So keep that in mind. So if he was hypotensive and tachycardic or getting septic, or he might not show the typical signs. So keeping that in mind. My next question was going to be, so now if we are thinking with the 1+ pitting edema, there is a question of heart failure and that kind of stuff. So do you know of a blood test that we can do to kind of maybe rule in or rule out heart failure component? I know the chest x-ray doesn't show pulmonary vascular congestion and stuff. It looks more like a pleural effusion and a pneumonia maybe. But is there a blood test that you guys know that we can do to kind of build a case?
You can do a BNP.
Woo! Yes, exactly. So BNP would be helpful, except you have to always take all these things with a grain of salt, because BNP, if he has like COPD, core pulmonale, or like pulmonary hypertension, the BNP could be elevated because of that. But nevertheless, if it is negative and low, then we can say like, okay, we are leaning more towards a COPD exacerbation. So those would be my initial thoughts. Now considering all the factors, so I think we can probably jump to kind of how do we stabilize the patient and what are our like urgent needs? So what can we do in terms of treatment?
John, what first comes to your mind? What do you think is the most important to start with in this patient?
I would say, you know, if we're worried about impending respiratory collapse or something like that, you know, he is breathing pretty fast, and if we think he's able to keep up with his breathing requirements, kind of based on where he's currently at, he's like not tripoding on us. He's not, you know. I think, you know, you'd always be worried about that. And do we need to intubate this person? I don't think, based on kind of what we know, he doesn't seem like we'll probably need to do that. But I think other things to stabilize, I think we'd start some IV fluid resuscitation, see if his blood pressure is responsive to that. With a caveat of if he's in heart failure, then I'll see that you don't want to do that. I'm just thinking out loud on that one. So that's kind of that might not be the best thing for him, actually. But yeah, I think those are the things that really jump out at me at first. You know, I think one thing definitely that you'd also want to be thinking about with the pneumonia picture, you probably want to get blood cultures and be thinking about sepsis as your underlying, you know, with that hypotension picture. I think his potential for like pitting edema is concerning for, you know, like maybe an underlying heart failure, but, you know, at the same time, he is hypotensive. So that might be beta blocker related, but that might be like sepsis related. So that's kind of what I'm thinking. I don't know if that was a great answer to Dr. Zufer's question, though.
I love it. Zach, I'm curious.
No, that was exactly right. Did you, though, mention, because your voice was cutting off, did you mention an ABG?
I did not mention the ABG, but that would be good because that's a good point, because, you know, if he's a COPD exacerbation person and he is retaining CO2, you know, you could see that might be an indication that you might need to start some like non-invasive BiPAP, that kind of thing. If he's super hypercapnic, that would be important to note as well. So yeah, definitely an ABG or at least a VBG for in the interim would be helpful as well.
Yes, exactly, because that will help. So between the BNP, between the ABG, these will kind of help kind of decide and triage a little bit. CRP, ESR, probably not so much right now, considering our diagnosis, because I don't think it's going to change our management all that much. So I think we're okay for now. So now at this point, I think prioritizing stabilizing the patient, so we can kind of do, till we have a definitive diagnosis, we've narrowed it down. But I think tackling all the things. So if we are thinking sepsis and we know there is an infiltrate and there is a pleural effusion, so we're thinking there's a pneumonia. So starting off with antibiotics, considering he's hypotensive and could be getting septic fluids. And so if it is sepsis, then 30 mils per whatever at that rate. And then he is in a supervised setting. So then they do like NICOM and that kind of stuff, the non-invasive cardiac output monitoring and whatnot, and see if they are fluid responsive. And then at this point, respiratory therapy for breathing treatment to see if that helps. And then other treatment like steroids, you would probably do a shot of steroids. So those would be kind of the initial things that you can kind of tackle all of them, kind of all these things happening at the same time.
That was gold. Thank you guys all. That was a great discussion. Zach, given this information, before we go on to the next aliquot of information on how he was initially managed, I want to know, what is your differential at this time and how has your problem representation changed for this patient?
My differential for this, I mean, pneumonia is definitely up there, but with his history of COPD, I think both of those are reasonable to assume are going on at the same time. So I think like a COPD exacerbation would be 1, pneumonia would be 1, and then combined could be a separate one, and any combination of those. But the thing is, I think we're going to treat for all 3 at the same time, and I think the treatments kind of overlap a lot here.
For sure, and definitely I like what you said, because typically a COPD exacerbation is triggered by something. Occasionally it can happen just from the progression of a patient's disease, but there's typically something, whether it's a viral infection, or pneumonia, or PE or environmental exposure or something. So you're totally on the ball that COPD exacerbation plus what do we need to treat? And this guy's given us a picture of possible pneumonia. So I think that's a really good thought to have and to keep in the top of your head. And John was on the ball about getting that sepsis workup going, because we know that with goal-directed therapy for sepsis, there's much better outcomes if we intervene early. So you guys are awesome. So I'll give you the next kind of aliquot of information here. So we were on the same page as you guys, diagnosed with COPD exacerbation, likely triggered by a pneumonia. So in the emergency department, he was given methylprednisolone, 60 milligrams, tiotropium, and albuterol. Initially, this is an interesting thing to know about currently. He was initially given those inhalers with an MDI, which is just like the normal inhaler, because his COVID had not come back yet. And so in the ED, they're trying to hang off on doing the nebulizers until the COVID tests are negative, because it's an aerosolizing procedure. So he was treated with an MDI at first. His COVID eventually did come back negative. So by the time he got to the floor, we were on nebulizers for the albuterol and tiotropium. And then after the IV steroid dose in the ED, he then was started on a course of prednisone, 40 milligrams daily for 4 days, empiric antibiotics of ceftriaxone and doxycycline for community-acquired pneumonia. And then we also started a budesonide formoterol inhaler on top of the albuterol tiotropium that we had been given. So that's kind of the initial management at that point. Was there anything that, John, we'll start with you. Was there anything missing that you feel like maybe should have been ordered that wasn't? Or anything else that you feel like might be beneficial, even if it may not be, perfectly indicated in at this point?
Yeah, one thing that I meant to ask previously, so he had the slightly worse on the left versus the right edema. So at some point in time, I would have liked to address that and get a lower extremity ultrasound to rule out DVT and PE. He had a really high respiratory rate. I mean, it's one of those things where it's like you don't want to miss that, and it's not like super cheap procedure, but you don't want to miss someone having a DVT and then they are having PE, and then that's the thing that's going to kill them, and they have right heart strain and you just don't see it. So I think getting an echo as well, and I mean, I see D Dimer in the chat as well. I think on him, that's always a question that, is that gonna benefit you or not? Because if you see that he has lower extremity edema and you get an ultrasound and there is something, I mean, you're going to anticoagulate them and treat him for a DVT and possible PE. And then if you see that and you're worried about a PE, you'd get a CTA as well. So I don't know that if you have a potential source of a DVT, I don't know that you would want that. Also, that can be elevated if he's got other things going in as well, or going on as well, if he's got some other, I don't know. I feel like D Dimer in this situation might just be elevated because he's chronically seems like he might have something going on. I don't know. That might be incorrect. Dr. Zufer might disagree and say that we should get a D Dimer, but I think definitely you'd want a lower extremity ultrasound on him.
Dr. Zufer, what do you think?
Yes, I would like to add something here. Now, if he has edema and an element of heart failure, I granted like it's asymmetrical, but D dimer has good negative predictive value. So if it is negative, then you don't even have to do the ultrasound. So D dimer actually is a good idea. I was thinking of that before. When you do initially, when you're trying to triage and narrowing down, then BNP and D dimer, these are all good tests to do in the beginning. And then you can say, oh, the D dimer was negative, so we can safely say that we are not concerned about thromboembolism, if that makes sense. But yeah, once you have done the ultrasound, then D dimer doesn't make any sense.
Yeah, that definitely makes sense. Because if you just want to get the D dimer and he's not, because if that's negative, then you're not even worried about that lower extremity.
Right, exactly. So a lot of times you use a D dimer, because if I was seeing this patient in the clinic and I was ordering stat labs, I would probably get a D dimer first to decide whether or not I need to follow it up with an ultrasound. But yeah, that was like a good point to think of, like PE and the DVT with the asymmetrical swelling on one side.
For sure. And
then another teaching point here I was going to say was the difference between an MDI and nebulizer. So technically speaking, if the MDI is used correctly, it delivers the same amount of medicine. So there's not like really evidence that a nebulizer works better and stuff. In certain situations when, patients are having like an acute exacerbation, they might not be able to take a big deep breath in which case the nebulizer kind of makes sense. But like for a teaching standpoint, or telling the patients when they want a nebulizer for home, you can tell them it delivers the same amount of medicine provided you're using the inhaler correctly.
That is an awesome pearl. I had no idea about that. And nebulizers are definitely more expensive. So that is a great pearl to know.
And another point that I might want to, I guess, go on. Yeah, I'll bring it up later.
Yeah, okay. Another quick point to bring up here is that MD-Calc has a really quick, awesome Wells criteria calculator. And so I actually just now pulled that up and put in our stuff real quick for this patient. And he is moderate risk. And so it does recommend going ahead and doing a D-dimer for him. Based on Wells criteria, if it's moderate risk, you start with the D-dimer. If it's high risk, you might even just go ahead and go to imaging. But be careful because there's a Wells criteria for DVT and there's a Wells criteria for PE. So make sure you're getting the right one with what you think is going on. You guys are right on the ball. We're also concerned about that lower extremity swelling. So we got a Doppler ultrasound. And the ultrasound was ordered just to rule out the DVT. It was kind of more of a, well, we might as well, probably better to check. Ended up that he did have an occlusive DVT extending from the left femoral vein down to the left tibiopopliteal vein. With this finding of this pretty extensive DVT, a CTA was ordered, and we found a non-occlusive saddle pulmonary embolus on CTA. Point of care ultrasound was done immediately as a rapid response was called, and it showed no evidence of right heart strain. The patient was hemodynamically stable, and so no acute surgical interventions were deemed indicated at that point. He was started on therapeutic heparin and moved to telemetry unit for more close monitoring. So, given this interesting finding, you guys are right on the ball with it. We've kind of identified what's going on in this guy. Is there anything else for workup at this point, or are we done? What are your thoughts?
I'd say whenever you have a DVT or PE, you want to say why, because there's two different kinds of like mindset wise if you're thinking of like clotting like that. It's like, is this provoked or is this non-provoked? Because do you have an underlying reason that you think he got this PE, whether it's like he's recently had surgery, he's recently been had some reason to have a hypercoagulable state that you can point to and say, yes, that's what provoked his clotting, versus completely unprovoked. There's no underlying reason to think that he would have a clot, and that kind of warrants a hypercoagulable workup. Regardless, you're going to be anticoagulating him in the same way. And so like acute management is not as important, but it is important for his long-term, and also how long he's on anticoagulation afterwards is a big part of that. Because if you think this is provoked, you have a source, it's a much shorter course of anticoagulation.
Right on it. Zach, what about you? Anything else that you'd want to do on this patient before sending him home?
Before sending him home? Well, I think he's getting admitted regardless, probably like ICU status or close to it, if not. My thought originally was the PE stuff, the PE DVT stuff. We already talked about that. I guess you could maybe argue his EKGs were fine. You might order some more EKGs later on if you're concerned about MIs or something, or serial troponins. I'm not necessarily worried about that, so I'm not jumping on that right now. Can't think of anything off the hand elsewhere.
Yeah, so I like that point that you make about the repeat EKGs. So that's largely why we put him on the telemetry unit, so that we could keep a close eye on his heart. And that's one of the benefits of being admitted. as compared to like, you know, the ED or anything like that, is that we can always be watching his heart, which is super helpful. And just to clarify, so this DVT PE stuff was actually done on the second day after admission. So he was in the ED kind of throughout the day on kind of day 0, admitted kind of in the afternoon, and then it was in the afternoon on hospital day 1 where we did this workup, and that night they found the PE. So hospital day 2, he's stable. Dr. Zufer, what comes to your mind? What else needs to be done for this patient?
I think you're muted again, Dr. Zufer.
I'm not doing a good job of this, am I? Let's see. So then if the patient is stable and we have answers, and we, provided we want to do like an echocardiogram or something, then that would be a different thing. But then we can kind of start thinking of discharge disposition as well. And then the steps and the logistics that need to go into it to kind of start planning of that if he's clinically doing okay.
Yeah, I think that's a really good point. Oftentimes we, you know, try and err on the side of caution and keeping our patients and making sure that they're stable, which is a good thing. But we also know that there's risks to being in the hospital. And so we definitely want to mobilize patients to be able to get up and get home sooner rather than later. And oftentimes that thought process needs to be going since the first day of the hospital stay, because sometimes there's social work issues and case management issues that need to be worked out that take time, such as, you know, this patient, he didn't really have a PCP. And so we need to be thinking about that workup, the disposition workup from the beginning, so that by the time the patient's medically ready to go home, they can actually go home and don't have to stay in the hospital and, you know, get C. diff and whatever else. So, John, what comes to your mind as far as like what needs to be done to get this guy home?
So you need to sort out so he can't go home on IV heparin. So you're going to have to sort out his anticoagulation situation. And oftentimes, like from a practical standpoint, that means figuring out what is his financial situation with his insurance, because can he afford like an apixaban, a Rivarox? Can he afford some of those novel anticoagulation, factor 10 drugs, or will he need to go on like warfarin? Because if he needs to go on warfarin, then you have to start that while he's in the hospital, bridge him with heparin, so that will lengthen his stay. And oftentimes that's where social work and pharmacy can help a lot. Especially, you'll see like during social huddles and rounds, or social huddles during while you're inpatient, you'll see, that conversation being had of, how much will this drug cost them? Do they have insurance? How can we help them? Can we give them a voucher for those things? Because, if they can get like a Xarelto or Eliquis or something like that, they can start that and they don't have to have monitoring. They don't have to have all that kind of stuff set up for when they leave, because, if they start on warfarin, then you have to, get their INRs checked as an outpatient. And so that needs to be set up. You need to figure out, do they need a PCP who tracks all of this and does their INRs? So that's, I think, one of the biggest things. And then also, he's come in with essentially maybe a PE, also pneumonia with a COPD exacerbation secondary to the pneumonia. And so then you're worried about, okay, he probably needs to have his COPD regimen modified. Do we need to add, in addition to his inhalers that he was on? I mean, he was on, I think, short-acting, he's on albuterol and tiotropium. So, I mean, with his exacerbation, you might consider adding an additional inhaled corticosteroid, maybe not, maybe adding a long-acting beta agonist as well. So, we can talk about that. I don't know if we have a little bit of time, we can talk about, where he would be at in terms of like his COPD staging. But that's another thing that needs to be addressed. And that might be something that can be more addressed as an outpatient, but you definitely want to be thinking about that while he's an inpatient. for sure. Those are kind of the things I'm thinking. And then also his antibiotic regimen and making sure you have that properly covered, is properly treated, and you have him on the right course and length of antibiotic treatment for the community-acquired pneumonia.
You guys are on it. This was great. By the way, beta blockers are not completely contraindicated in COPD, exacerbation or COPD in general.
Yeah, that actually reminds me, it's interesting.
So according to my information,
I think we might be having some connectivity issues here.
Yeah.
All right.
So somebody was saying something about beta blockers.
Oh, I was just going to mention, when I was rotating with cardiology, they were mentioning, it's really important as a student to know the percentages of beta 1 versus beta 2 activity on all the different beta blockers, because some drugs, especially in the cardiac regimens, things like antiarrhythmic drugs, the sotalol, those actually have more beta 2 than beta 1. So there was a patient that we had who was admitted for AFib, and they did an ablation, and they had him on a sotalol drip, and then he was wheezing like crazy, and they're like, what the heck is going on? And it's because it is a beta blocker, even though it's antiarrhythmic. So, and just in general, kind of to your point, it's like always be thinking about, what is the actual mechanism of action? And you can look up online, there's tables that show the percentage of beta 1 versus beta 2, and if they have any alpha activity as well, that can kind of help you risk stratify when you're thinking about that, because, if they have heart failure and they need full directed medical therapy as well, you need to kind of be thinking about those.
So yes, great points. And then, like, pharmacologically, if you think about it, the albuterol is a beta agonist. And then on the other hand, you're giving a beta blocker. So you're just kind of basically doing two medicines which are going to oppose each other. So in the big picture, the cardioselective beta blockers, so metoprolol, and my understanding is the metoprolol succinate up to a dose of 100 milligrams is cardioselective. So beyond the dose of 100 milligrams, it loses its cardioselectivity. And so then at that point, it can cause bronchospasm. So metoprolol is fine. Carvedilol, I think, because if you think about it, the most common beta blockers, if it is a heart failure patient, the three guideline-directed ones are metoprolol, bisoprolol, and carvedilol, right? So carvedilol, I think there has been, I was looking at some studies and stuff, small sample, where it was like one of them said that it does decrease the FEV1 and can lead to bronchospasm, and another one, but it was only 11 patients, it did not make that much of a difference. But metoprolol should be a safe one. So if we have like somebody with heart failure, and then kind of when you start them on the medicine, or if they are on the medicine, then kind of keeping that in mind that they are on a beta blocker, is that making it worse? But cardioselective metoprolol should be fine if we have to use it.
Again, gold. You guys are amazing. I think before I give kind of the wrap up of the case, Dr. Zufer, I know one question that has been posed commonly before when I've been on the wards is, when you have a patient like this with COPD exacerbation, possibly from pneumonia, one of the acute treatment things for COPD exacerbation is steroids. But if a patient has pneumonia, can you help us kind of, clarify that kind of cognitive dissonance that we might have in our head between giving a patient with infection a bunch of steroids?
That is a good question. Let me think. So now, evidence-wise, I don't know if I can quote something over here, but if we have like kind of a documented most likely bacterial infection, then it is the risk and the benefit. So in this case, we will need to treat the infection. So then it will be kind of risk and benefit, but in this situation, the patient will need both. So it is just like each, if it is like a question of like, oh, maybe it is we're not sure that it is infection, and it may or may not be, in that case, you might kind of think about it. But otherwise, typically this patient needs a steroid and he needs like an antibiotic, both.
Awesome, thank you for that. All right, so a little bit of resolution for this case. So the following day, so hospital day 2, A full echocardiogram was done that showed normal LV and RV function with an LVEF of 55% and no right heart strain. He was transitioned to a DOAC, which is a direct oral anticoagulant. We chose apixaban. There had been a recent study that I encourage you to look up. I can't remember the name of it right now, but that did show that apixaban compared to rivaroxaban has a lower risk of bleeding and about the same efficacy, if not maybe a little bit better. So we went ahead and went with apixaban for this guy for long-term anticoagulation. He did have a history of a stroke about 7 years prior, and so in consultation with our cardiology colleagues, it was determined that probably lifelong anticoagulation was the best treatment for this patient. We also worked with our case management and social work team to make sure that he had close PCP follow-up. We got him established back in the family medicine clinic at KU so that he could be followed much more closely and make sure that he get the stuff that he needs at home, because he did have some socioeconomic needs. So with that kind of resolution, any final comments just kind of on the case, the patient itself? We'll start with Zach.
I think it's a good case. I mean, this is basically what happens on wards and in the ER and in family med clinic all of the time. So I think always remember to not miss the things that will kill you, like a PE, because it's so easy. Like on day 2, you're like, oh goodness, we didn't get a D-dimer kind of a thing. Even though like you're sitting there thinking, oh, this is obviously COPD, just always remember those other things.
I'd say a couple of things to be thinking about is, the mechanism of the thing that kills you with the PE is right heart strain. So that's why it's really important to get that echo and kind of if you haven't seen like a PE activation, so they'll activate a PE, and so the pulmonary and then the interventional radiologists and the cardiologists and the fellows of some of those, and sometimes it's attendings, will kind of get on a conference call together, talk about what they're seeing. The cardiology fellow will go and do it like a stat echo on them, look for right heart strain, IR, and then they'll look at the imaging and they'll say, is this something that we need to intervene on? Because that's another thing that sometimes will happen, is that interventional radiology will go and do like a clot removal essentially. And so it's a multidisciplinary activation. So that's something that if you see a PE on the wards and it's diagnosed, and they'll call that. But a couple other things to think about with PEs, just because it's kind of interesting, is, if you're having right heart strain, you can have an elevation in troponin with that. Because I saw a patient who had significant right heart strain. We had no idea he had a PE. They got an echo, and then his right heart was barely moving and his troponin was really elevated. And so we were thinking, oh, is this an MI? Is he having something? And it turned out to be a huge PE, a huge saddle emboli. And so I think that's just another interesting thing about PEs, that if you see that elevated troponin, don't think, oh, this is an MI, got it. Kind of unrelated, but an interesting point as well.
Yeah, this is great. And I think keeping an open mind is super important. And so many times, even like going to the ER, a lot of times when the ER is checking out a patient for admission, and if we are busy, there's 2 or 3 admissions and a lot of stuff going on the floor. They say like COPD exacerbation, you just kind of quickly go through the motions, put in the orders and start COPD treatment. And that's when you kind of, if you're not thinking of the other things, you're not going to do any of the other stuff. So that is always super important. And it happens so many times, because if the ER is rushed or if we are rushed, then a lot of times what gets passed on to us, we don't question it. And then that's when kind of mistakes can occur and we can miss things.
Yeah, and I've gotten like great pieces of advice from residents and attendings, when you start on like medicine rotations, oftentimes, and family medicine and internal medicine inpatient, you might not be the one doing the HPI. You might not be being the first one who starts, and there's already a treatment plan going for you, but as a student, don't necessarily look at the treatment plan. but, you know, get an idea of what it is, go and see them, look at their vitals, you know, things like that, so you have an idea, but formulate your own thoughts about what's going on before doing that, because otherwise it's really easy to anchor yourself and also not be thinking and learning about it. But that'll help, like Dr. Zufer saying, you know, you don't want to just say, oh yeah, this is absolutely what it is. This is the treatment course. It's already set in motion. We'll just keep going. You know, don't forget about, you know, like the PEs, the things like that, you know, needs to be evaluated is definitely really important. That's extremely common, like Dr. Zufer is saying.
Oh, and then, yeah, the stuff that you're typing, another thing to think about, like COPD exacerbations on the floor, we don't want their oxygen stats to be like 100% or 99% and stuff. So a lot of times the nurses will tend to kind of raise the oxygen level to 4 liters or 5 liters or whatever, trying to get the O2 sats too. So it is very important for nursing communication that this is a COPD patient and we don't necessarily want the oxygen level to be above 92%, because I think it decreases their respiratory drive and then can lead to more hypercapnia and whatnot. So that is another point to remember. And then that also then delays the discharge, because if they're saying like, oh, patient is still requiring 4 liters of oxygen with no baseline home O2 requirement, but then you think about it, if you look at the O2 sats, they are like 98, 99%. Okay, we don't need them to be 98, 99%. So then you can easily wean it down to where they are no more than 92%. And for them to qualify for home oxygen, the O2 level, O2 sats have to drop to less than 88%, less than 89%. So if they are more than that, they will not require home O2. And then one of the logistical things to do kind of an ambulatory oximetry before discharge. So if at rest they are doing okay and not requiring oxygen, then we make sure that respiratory therapy walks the patient to kind of make sure that they're not requiring when they are walking.
Yes, for sure. One of the beautiful elements of multidisciplinary care that we can get the best care possible for our patients by utilizing the expertise of our colleagues. Thank you guys so much. That was an awesome discussion. One last pearl that I just wanted to verbalize, I wrote it on the teaching points here, but after I had this patient, after just doing a bit more research, I saw that pulmonary embolism is actually present in 20% of COPD exacerbations and 25% of those that are hospitalized. So definitely something to keep an open mind to. And something that my attending pointed out when we had this patient was to have an even higher index of suspicion, well, lower index of suspicion, I guess, higher suspicion for DVT PE in the area of COVID, because we've seen in a lot of the reports and stuff that COVID is causing a hypercoagulable state. And I know John was talking about that earlier with working up a PE. So if a patient might have an asymptomatic COVID infection or pre-symptomatic or maybe symptomatic, maybe that's contributing to something or maybe being the cause of his exacerbation. Not in this patient, but it's something to remember that our patients might be extra hypercoagulable if they've been exposed to COVID. So it never hurts to be a little extra cautious when a patient's in the hospital and keep your mind open. So with that, Kelsey, do you want to give us a few of the quick high points from the teaching points, and then we'll call it a night?
Yeah, absolutely. So a couple of big teaching points. The big one is that meter dose inhalers can be equivalent to nebulizers as long as you're using the inhalers correctly. You just mentioned PE being present in 20% of COPD exacerbations, so definitely think about those. Only interventions shown to reduce mortality in COPD are smoking cessation and home oxygen if indicated. And I was just looking those up, but I didn't type them on here, but the main indications for home oxygen would be a PaO2 of 55, an oxygen saturation less than 88, or a PaO2 of less than 59 if they have evidence of cor pulmonal or polycythemia. So those can be reasons you would send them home on oxygen, and that's assuming they have otherwise good management, good regimen. And then right heart failure is what kills in the setting of a PE, and keep your SpO2 goal of 88 to 92%. And then just kind of as a general, I underlined them right over here, but for the management of acute COPD exacerbation, you'll want to give albuterol and tiotropium nebulizer, so beta-2 agonists and anticholinergics. Antibiotics if it's a moderate to severe exacerbation, and And then you want to give systemic corticosteroids and then giving oxygen generally via nasal cannula. You can add a face mask or non-invasive positive pressure ventilation if needed for that.
Awesome. Great pearls.
Oh, one last thought I just had when you mentioned the epitropium and the tiotropium. So keep in mind in elderly patients, they can increase the risk of anticholinergic side effects. So if you're thinking about it, if they are on tiotropium already at home, it is a long acting, so it should kind of be sustained level in the system. So then you probably don't want to do a PRN Atrovent. In the ER, when you're treating an exacerbation, that's a different thing, but you have to keep that in mind as well. Don't do too much anticholinergic stuff. They will get like urinary retention and all the other anticholinergic side effects.
Super important for our elderly patients. Thank you so much for that extra pro right at the end. All right. Thank you guys so much. This was a super cool discussion. I know I'm going to be going back and watching this again. For everyone we will be posting this on our YouTube channel pretty soon here. And for anyone on YouTube, thanks for watching. Alrighty, guys. Have a great night. Any last burning comments? Otherwise, we'll call it a night. Alrighty. You guys are awesome. Keep it up.
All right. Good night.
Night, guys.